Okay, I'm Dr. N Singh, and I'll be basically dealing on VI-RADS. That's the Vesicle Imaging, Reporting and Data System. It's in the same lines of VI-RADS, everything, whereby we try to have a objective measure of what is happening as far as imaging is concerned, so that we can have a risk stratification in this case. So now, bladder cancer. Why bladder cancer? For the last 10 years, this is the US data which shows that estimated death rates and estimated incidence both are nearly static. I mean, it is not reduced, and thus this is an important issue as far as a clinical disease is concerned. I have been told that out here also there are 40 new cases per month which we are getting at Mahamana, and thus it's a potential problem. So importance is, in case we pick this up early, we have a 5-year survival rate of what is depicted here: 96%, 70%, 39%, 8.3%. So we need to pick this up early, stage this accurately, and go ahead with treatment in precision. Bladder cancer staging. Why do we need VI-RADS? Bladder cancer staging is T1 is lamina propria, T2 is muscularis, T3 is involving the perivesical fat. Now the importance is T2 whereby it comes the muscle invasive, non-muscle invasive. Again, because as Dr. Akhil said, the treatment route changes, and there we pitch it. That's the VI-RADS. Again, the lymph nodal involvement, this can be just for a theoretical purpose and for SRs. Like, this is no lymph node involvement as for N0. N1 is bladder carcinoma involving one regional pelvic lymph node. Importance is that the regional pelvic lymph nodes are defined as inguinal, hypogastric, obturator, external iliac, perivesical, and presacral lymph nodes. So, and N2 is one regional more than one regional lymph node, and N3 is positive lymph node along either of the common iliac vessels. So, common iliac vessels, bifurcation, and then subsequently metastasis is anything above the aortic bifurcation. So there are two bifurcation: aortic bifurcation, common iliac bifurcation. One is metastasis, the other one is the regional lymph nodes. M1A disease, M1B disease. Again, M1A disease is lymph node, M1B disease is metastasis to other organs. This is again a schematic representation whereby we see internal iliac artery, the perivesical lymph node. These lymph nodes becomes the metastatic lymph nodes. So why VI-RADS? VI-RADS is a multi-parametric bladder MRI evaluation, a structured reporting scheme for a risk stratification system and systemic imaging approach, and it has been developed by the European Association of Urology in 2018. Imaging options in MRI: T2 weighted image, T1 and post-gadolinium T1 contrast, and then subsequently the diffusion weighted images to see, accompanied with the ADC to look for further imaging characteristics. The summary is the same which I just mentioned. T2 and post-gadolinium contrast, that's the T1 post-gadolinium contrast, defines anatomy and the muscle invasion. In case of any issues, diffusion weighted image comes to our rescue. Important thing as far as clinician is concerned: bladder cancer management, whereby the non-muscle NMIBC, TURBT is generally done, and then residual tumor treatment with intravesical BCG. These are radiologic treatment. We'll have to confirm with the uro-oncologist. And up to T1 stage is what is NMIBC, and treatment is aimed at reducing the local recurrence and stage progression and maintain quality of life. In case if there is muscle invasion, same TURBT followed by induction therapy, cystectomy, consolidation. These are the T2 and the T3 stage, and subsequently the treatment is aimed to reduce stage progression and preserve quality of life. So this is an important slide whereby this VI-RAD comes into picture and can reduce the multiple discordance and concordance between various people. Like the surgeons, their ability depends on the exposure, training, and the experience. The pathologist may disagree in bladder cancer grading and staging, and the radiologist differs in agreement about muscle invasion. The lower the power of the magnet, the more the disagreement between the radiologist. So that is how we have to approach. So what is MPMRI offers an opportunity to reduce staging error, and with no X-ray exposure, it's an ideal, I would say, imaging modality to do it. I mean, any number of times, because in oncology we do it quite frequently. Again, challenges related to bladder cancer is staging error. Always, starting from TURBT to MRI, you name an imaging modality, staging error is there. Aggressiveness of bladder cancer. It is said that despite improvement in surgical techniques, overall 5-year survival rate after radical cystectomy is 50 to 70%. And thirdly, problems in treatment. Ladies and gentlemen, we all should know that bladder cancer survival is strongly dependent on, on treatment delivered rather than the intrinsic aggressiveness of the tumor. This is a very important line. So now the investigation, the workup of the patient is a very important step in bladder cancer management. So what is rationale? We have a primary diagnosis, we have a therapeutic planning. This needs to be improved in case VI-RADS gets in. Again, the same thing, to optimize the diagnostic pathway management and to minimize cost related to bladder cancer. I've been told by the oncologist that repeat TURBT is in the range of 30 to 40%. That's like both, financially as well as the patient, it's an issue. So we can, the VI-RADS can chip in. Coming to VI-RADS, what is VI-RADS? Again, more or less, this is a T2 weighted image, and whereby we can see that this is the urine, normal urine appearing bright. This is the muscle, which is dark, and this is the tumor. This is the tumor. So this entire thing is the low single intensity muscularis mucosa. This is what needs to be evaluated. The theme is this what needs to be evaluated. So T2 weighted image, mass lesion, intact mucosa, stalk. This is hypo, this is on contrast, it enhances. On diffusion weighted, it is hyper, and on ADC, it is low. This is a malignant mass, and VI-RADS, this is either 2 or less than 2. Depending on the size of the tumor, less than 1 centimeter, more than 1 centimeter, it can be VI-RADS 1, VI-RADS 2. But either way, it is less than 2. 2 or less than 2. So, this is the same, zoomed image of the same thing, whereby we can see this hypointense line, which is the muscularis mucosa. This is VI-RADS assessment category, whereby VI-RADS 1 is muscle invasion is highly unlikely. The thin, low single intensity muscularis is seen. VI-RADS 2 is unlikely to be present. Mostly, it is less than 1 centimeter and more than 1 centimeter mass. VI-RADS 3's presence of muscle invasion is equivocal. It is not clear. Okay. D4 is muscle invasion is likely. We generally see the muscle invasion, but it doesn't, cross the outer margin of the muscle. And VI-RADS 5 is invasion of the muscle and beyond the bladder is very likely. These are the algorithm which we work on. This is a very crowded slide, but I'll go on to the main components of this. 1 is less than 1 centimeter. 2, this VI-RADS 2 is more than 1 centimeters, whereby a exophytic tumor with stalk is seen or with a high SI thickened inner layer is seen. There is a hypo-intense lesion between the line, that's the low single intensity line, and the tumor. When this is lost, we go to 3. With an almost clear line, when this is lost, we go to VI-RADS 3. And on a structured category, this thing, and on a dynamic contrast, there's no clear disruption of the low SI muscularis propria. So, what I mean to say is 1 and 2 is clear. It's very easy to demarcate between 1 and 2. 5 is also clear because it is perivesical spread. It's clear. Problem is in VI-RADS 3 and VI-RADS 4. That is where we have discordance, and that is where we should be more careful in giving a scoring. So, interruption of the low SI line, in case if it is there and it is not crossed beyond the muscularis mucosa into the perivesical fat, then it is 4, and if it has crossed perivesical fat, it is 5. If it is that, then in that case it becomes a T3 lesion. Again, this is all algorithms say the same thing, whereby we arrive at the grading, where SC1 is structural component, SC1, 2, 3, 4 and 5, the one which we discussed, with permutation and combination of contrast enhancement and diffusion weighted images. Again, with these things, we arrive at a scoring. So, coming on a schematic diagrams, this is what it is, why I was talking about the stalk. This is the tumor, this is black line is the muscle, there is a stalk in between, and this, if it is less than 1 centimeter, it is 1, if it is more than 1 centimeter, it's 2. Now in 3, we see there is no stalk, and at times it can be a thickening of this line, the low intensity line, it can be 3 then. If there is line, low signal SI line is not very clear, there is some bulbous, there is a margin out here, the inner margin is not clear, and a sessile growth, this can go into VI-RADS 4, and here what we see is VI-RADS 5. It has gone into perivesical space. Again, some part of radiophysics. Here what we see is that this is hypo-intense muscular layer on a T2 weighted image, but on enhancement, initially it is hyper intense and subsequently it becomes hypo intense. So initially the muscle and the mucosa both enhances on a similar note, but on a later stage the muscle starts becoming hypo intense, the mucosa remains hyper intense. So VI-RADS 1, this is mass, this is the intact lesion, post contrast enhancement, diffusion hypo, and this is VI-RADS 1. Okay. VI-RADS 2, more this lesion is more than 2 centimeters. The intact low signal intensity mucosa, same features of imaging. This is VI-RADS 2. Again, the stalk is seen all the places. In case of VI-RADS 3, this is the zoomed image of the same, whereby this is the line, intact line, more than 2 centimeters. We go to VI-RADS 3, this is hematoma, forget about it. This is the lesion, sessile, and then it is adhered to the line. Again, this is what the radiology, radiophysics I was talking about. The thing here out to delineate the muscle, we need to have a delayed images, whereby we need to differentiate between the mucosa and the muscle mass. In case the muscle is interrupted or minimally interrupted, we can take it as VI-RADS 3 and VI-RADS 4, depending on the amount of or the depth of penetration. Again, the zoomed images, this is what it is. We can see the hypointense line out here, but here it is a bit disrupted. So again, VI-RADS 3, it can be VI-RADS 4 also. This is VI-RADS 4, whereby this is a sagittal view, whereby we see that the inner margin is lost out here, outer margin is seen, it's not spread into the perivesical space. The same, this is an, the tumor is out here, and we can see that there is enhancement, there is diffusion weighted restriction and hypointensity. Since it has inner margin is lost, it is a extension into the muscularis mucosa, and then this can be defined as VI-RADS 4. And now we come to VI-RADS 5, whereby the tumor goes outside, into the perivesical space. So this is, ladies and gentlemen, VI-RADS in a nutshell. Again, pooled weighted sensitivity and specificity in this case is for VI-RADS is around 0.87, and I would come to I do have multiple cases, but with the restriction of time, I think I'll come to the take-home message that MRI is 80%. Has got more than 80% accuracy in differentiating NMIBC from MIBC and organ confined disease, whereby we can reduce the repeat TURBT. Again, higher soft tissue contrast and multiple sequences can better differentiate muscle invasion. And with we having a 3 Tesla MR, it is, I would say it's the results are there. MRI tends to overstage disease at times. At times, if it is not taken in a correct way, it tends to overstage disease. whereby in case if it is an oblique orientation, in that case we can so it has to be read by an experienced radiologist. In low-grade tumors, contrast washout is higher than high-grade tumor. This is a bit of a thing that whereby contrast enhancement is more, thereby we take aggressiveness as high, but here it is the other way around. And VI-RADS is a tool for risk stratification in bladder cancer. Okay, for the clinicians, when do we do timings of MRI and bladder treatments? It is basically TURBT and intravesical BCG. The thing is that we should do it either before these procedures or at least 2 weeks after TURBT. So that's important. And the other thing is very common things like cystoscopy and indwelling catheter. So they can have some air in the bladder because of this process. So at least a 2 to 3 day interval between cystoscopy or removal of Foley's catheter is desired, because MRI examines is recommended, because diffusion weighted images, because of the air, they can give susceptibility artifact. So these are the two things which I've thought I should share it with you. And I think with this, I think I've given a brief nutshell of the entire VI-RADS. Any questions?
Yes, the use of VI-RADS has increased in our setup as well. So I will take comments from Himanshu sir. How we are using VI-RADS, how it has helped you to decide the further steps.
So in the cases where re-stage TURBT is required, means the high grade we have done TURBT, एक बार TURBT किया, उसके बाद उसमें high grade आ रहा है, और but that has come T1, that is lamina propria invasion, muscle is seen but it is not seen invading the tumor is not seen invading the this muscle. So what happens on the somewhere around 5 to 6% of the cases ही उसे ऐसे होते हैं जिसमें tumor is high grade but it is non-muscle invasive. So usually अगर layman की terms में बोला जाए, because it's a perceptorship, so अगर common इंसान को बोला जाए, जैसे जब हम counsel करते हैं patient को कि अगर ये कैंसर हाई ग्रेड है तो मोस्ट प्रोबेबली ये मसल इन्वेसिव होगा, यानी आपकी मांसपेशियों में पहुंच चुका होगा, बिकॉज जैसा आप सब जानते हैं कि ट्रीटमेंट डिफर्स. सो वंस इट इज अ नॉन मसल इन्वेसिव ट्रीटमेंट इज मोस्टली ब्लैडर प्रिजर्वेशन, और अगर ये मसल इन्वेजन हो जाता है तो फिर वेरियस ट्रीटमेंट ऑप्शंस फ्रंट्स ओपन हो जाते हैं कि पेरिऑप कीमो विद ब्लैडर निकालना है, सिस्टेक्टमी करनी है, या कीमोथेरेपी प्लस रेडियोथेरेपी देनी है, जिसकी अपनी अलग अलग मॉर्बिडिटीज होती है. तो VI-RADS का मेन रोल जो है, जो अभी तक जो सबसे ज़्यादा रोल इस उन केसेस में है जिसमें अगर VI-RADS हमें ये बता सकता है कि जिस केस को हम ऑपरेट करने जा रहे हैं, से फॉर एग्जांपल VI-RADS रिपोर्टिंग करी है VI-RADS 4 और 5, और अगर हमने उसको TURBT किया और वो आता है कि ये नॉन मसल इन्वेसिव है, मसल दिख रही है लेकिन नहीं है, सो इसका कंकरेंस पॉजिटिव या नेगेटिव प्रेडिक्टिवली जैसे पायरेट्स के साथ है. प्रोस्टेट कैंसर में जब पायरेट्स करते हैं, सो व्हाई पायरेट्स बिकेम सो फेमस, और ये मतलब है ना इतना ज़्यादा हो गया कि आज की तारीख में पायरेट्स जो है वो एक इंडिस्पेंसिबल काइंड ऑफ थिंग हो गई है फॉर सीए प्रोस्टेट, स्पेशली ऑर्गन कन्फाइंड में. क्यों? क्योंकि सीए प्रोस्टेट का जब पीएसए सपोज किसी का आया कि 8 है या 10 है, अब वो 9 है, अब हमने सारा वर्कअप कर लिया लेकिन अभी भी पीएसए कल्चर अपलोड कर लिया, सारी चीज़ अपलोड कर ली, लेकिन पीएसए अभी भी 6-7 पे आ रहा है, पेशेंट के दिमाग में कि कैंसर है कि नहीं है. सो मैं प्रोस्टेट इसलिए लाया हूँ क्योंकि VI-RADS का कंसेप्ट VI-RADS से जुड़ा हुआ है. सो जब शुरुआत की बात है, जब लोग रेडिकल प्रोस्टेक्टमी नहीं करते थे, ये बहुत मॉर्बिड प्रोसीजर माना जाता था. आज की तारीख में विद अवेलेबिलिटी ऑफ द रोबोट्स एंड ऑल दोस थिंग्स, रेडिकल प्रोस्टेक्टमी कैन बी डन विद इन 2 to 3 hours. सो क्या हुआ कि प्रोस्टेट पीएसए बढ़ गया. जब पीएसए 80s में आया तो 80 उससे पहले डीआरई होती थी, डीआरई पे आपने नोड्यूल मिल गया, हार्ट प्रोस्टेट मिल गया, डायग्नोसिस हो गया, इमेजिंग स्टडी पे ऑर्गन कन्फाइंड है तो प्रोस्टेटेक्टमी कर दो. बहुत बेसिक आइडिया था, ऑर्गन कन्फाइंड है प्रोस्टेटेक्टमी कर दो, लोकली एडवांस है रेडियोथेरेपी दे दो, या मेटास्टैटिक है तो जो भी अपने पास ट्रीटमेंट अवेलेबल थे डीएस वगैरह जो थे. सो सडनली एक आता है पीएसए आता है अपने पास. तो पीएसए वाज गेम चेंजर. तो उसने क्या किया कि एक स्क्रीनिंग मॉड्यूल स्टार्ट किया, तो पीएसए से स्क्रीन करना चालू किए. तो अब क्या है कि अगर आप PSA का डेटा देखेंगे तो जैसे जैसे एज बढ़ती है वैसे वैसे PSA भी बढ़ता है, प्रोस्टेट की साइज पे भी डिपेंड करता है। प्लस क्या होता है कि अब PSA आ गया, किसी का 10 आ गया, 10 आते ही PSA उसको सर्जन से लेकर के पेशेंट के दिमाग में घूम रहा है कि यार इसको तो प्रोस्टेट का कैंसर है, बायोप्सी कराई, प्रोस्टेट कैंसर डायग्नोज हो गया। अब प्रोस्टेट कैंसर डायग्नोज हो गया तो वो उसका या तो रेडिकल प्रोस्टेटेक्टमी हो जाती है, या उसको रेडियोथेरेपी मिल जाती है, या उसको सम सॉर्ट ऑफ हार्मोनल ट्रीटमेंट हैज बीन स्टार्टेड। तो हुआ क्या, देन केम रोबोटिक्स। सो रोबोटिक्स ने क्या किया कि मैन्योरेबिलिटी और ईज ऑफ द सर्जरी बढ़ा दी। ईज ऑफ सर्जरी बढ़ाते ही अचानक से रेडिकल प्रोस्टेटेक्टमी की रेट्स जो है वर्ल्ड वाइड मतलब स्काई रॉकेटिंग हो गई। क्यों? क्योंकि हमारे पास अब रोबोट है, हम रेडिकल प्रोस्टेटेक्टमी करेंगे। सो अमेरिकन डेटा, यूएस वाले जो होते हैं वो डेटा के मामले में बहुत शानदार है। तो उन्होंने एक डेटा निकाला ओवर द पीरियड ऑफ, जब उन्होंने रेट्रोस्पेक्टिव एनालिसिस उनका किया तो उनको पता चला कि अप टू 1/3 ऑफ द पेशेंट एक्चुअली थेरेपी, सब कीमोथेरेपी फॉलोड बाय सर्जरी, और ये सो मेन रोल वायरेट्स का वहीं होने वाला है और वहीं पे है। सो इट इज नॉट फॉर T1, नॉट फॉर T3, क्योंकि T3 इज बट ऑब्वियस। सो मेन सारा किस्सा होता है कि हमारा सारी स्टोरी होती है कि हम T2 किसी तरीके से डायग्नोज करें, क्योंकि ट्रीटमेंट वहीं से चेंज होता है। सो अगेन T2 और T3 में भी हमारा 5 ईयर सर्वाइवल रेट बहुत ड्रास्टिकली डिफरेंट होता है। सो अगर ये T2 है और अगर हम इसको पेशेंट को इन्वेजिव एक और प्रोसीजर से बचा सकते हैं, कॉस्ट, क्योंकि अगर आप देखेंगे तो कॉस्ट एनालिसिस, सीए ब्लैडर इटसेल्फ, कॉस्ट उसकी, कॉस्ट टू द पेशेंट एंड कॉस्ट टू द हेल्थ केयर इंफ्रास्ट्रक्चर बहुत ज़्यादा है। क्यों? मसल, नॉन मसल इन्वेजिव है तो उसको BCG डालना है, या मसल इन्वेजिव है तो उसको कीमोथेरेपी लगनी है, अगर हाई ग्रेड नॉन मसल इन्वेजिव आता है तो रीस्टेज टीआरपीटी। तो पर से एज फार एज द यूरो ऑन्कोलॉजी इज कंसर्न, उसमें सीए ब्लैडर का कॉस्ट बर्डन टू द हेल्थ केयर इंफ्रास्ट्रक्चर इज वेरी वेरी हाई, रादर वी कैन से इज द हाईएस्ट। क्योंकि पेशेंट को और हेल्थ केयर इंफ्रास्ट्रक्चर को हमें नहीं पता चलता। अगर आप NHS की बात करेंगे जहाँ पे हेल्थ केयर सिस्टम इज ऑलमोस्ट फ्री, उनका डेटा है कि उनके लिए यूरो ऑन्कोलॉजी पर से का हेल्थ केयर में एक्सपेंडिचर सीए ब्लैडर में बेहद ज़्यादा है, क्योंकि पेशेंट री-टीआरपीटी कराने आता है, BCG कराने आता है, कीमोथेरेपी कराने आता है, पेशेंट को खुद बार बार आकर के सिस्टोस्कोपी करानी है, बहुत सारी चीज़। सो वायरेट्स का मेन रोल है। T2 अगर वो हमें बताते हैं, सपोज 4 और 5 बताया तो आई कैन गो अहेड। अभी तक हालांकि वाइड स्प्रेड प्रैक्टिस नहीं है कि अगर वायरेट्स स्कोरिंग 4 और 5 बताई जाती है तो फिर भी हम रीस्टेज पे जाते हैं, क्योंकि अभी तक गाइडलाइंस अभी तक साउंड नहीं है, या गाइडलाइंस हमें नहीं कहते कि रीस्टेज नहीं करेगी। सो देयर आर ट्रायल्स गोइंग ऑन जो हमें जब स्टैब्लिश होगा बता देंगे कि यह गाइडलाइंस में आ जाएगा कि अगर वायरेट्स 4 और 5 आता है और हाई ग्रेड आ रहा है, चाहे T2 नहीं आ रहा है, गो अहेड विद टेक इट एज अ T2। सो दैट इज गोइंग ऑन। सो मेन रोल वायरेट्स का वही है। इट इज नॉट फॉर द पर से प्राइमरी डायग्नोसिस ऑफ द ब्लैडर कैंसर के लिए वायरेट्स नहीं है। वायरेट्स का मेन रोल है हमें इन्वेजिवनेस बताने के लिए कि हम रीस्टेज करें कि नहीं करें। मेन रोल वायरेट्स का सारी स्टोरी वहाँ से। सो दैट इज द
Very highlighted, very detailed by violets, because usually there is a confusion in the mind that what is actually violets. So very beautiful pictures shown by sir, and that has clearly highlighted what is actually violets. Any additional comments, sir?
Yeah, some additional comments like Dr. NAC and then subsequently evaluate those patients again. Much data are not available. I mean, things like 10 cases or 15 cases के series पे people have come out with some. So that is another place where keep NAC or immunotherapy whatever, and then we can plan a protocol and then again we can think. Thank you.
Thank you, sir. Thank you.